Hello, everyone. Welcome back to lesson 2. This is the Mammography Registry Review lesson. In this lesson, we are going to talk about image production. In the last lesson, I went over patient care. If you want to check that out in the Mammography Review playlist. So in this lesson, it's going to talk about image acquisition and quality assurance. This is the content outline for the mammography for the physics section. So when I say image production, we're talking about physics. It's going to talk about the KVP, the mammography tube, how you are obtaining the images, MQSA regulations, ACR. We're going to talk about PACS in this lesson as well because when you work in X-ray, mammography, any type of radiology imaging, you have to send the images over to PACS. We're also going to talk about QC, any test that the medical physicists have to perform, any test that the mammography tech have to perform under QA and QC. And then more information on QC. This can be found on the ART website if you want to know where this information is coming from. And then on image production, we're still talking about KVP, mass, focal spot, your grids, magnification, positioning, compression. So now we will get started under all of the physics section, which is a lot. So just make sure that you're understanding this and paying attention. So for this section, the design characteristics of the mammography or mammogram unit. So as you know, all mammogram units do have a KVP and a mass range. Just make sure that you are paying attention to it because I know there's a KVP range is going to vary depending on the breast size or breast thickness. For the mass, I've seen it set with the AEC. So if you want to go in and change the mass, you have to take the AEC off and just change the tab to manual so you can put in a manual mass. If you need to, I'm normally seeing a mass adjusted for breast implants. I have not had to adjust my mask for just regular breast imaging. So pay attention whenever you are at work and pay attention to what KVP and what mass range that you are taking the image under. And the X-ray tube of the mammogram unit has a cathode and anode similar to X-ray, the X-ray equipment. And most units do have that black detector where the breasts do rest on before you come down with the compression paddle. That black area or board is the detector. The compression paddle is above the detector. We all know it can move up and down. I always demonstrate this to the patients before I start compressing, just so they know how it works. I've been told from patients that they are scared because they thought the machine gives the compression, but I let them see me demonstrate that I have control over the compression. And then with the compression paddle sizes, remember you have a 18 by 24 centimeters and a 24 by 30 centimeters. The 18 by 24 centimeters is going to be a little bit smaller than the 24 by 30 centimeters. And then for the compression device, that is going to increase the image quality by reducing breast tissue thickness while still allowing the x-rays to penetrate the breast tissue. So if a patient is asking you, why do y'all have to squeeze so much? This is hurting me. Just let them know that we're getting or trying to get great image quality because if we don't squeeze, I'm not saying you have to squeeze 40 to 50 pounds. You have to go by number one, what your patient can tolerate, and number two, the adequate amount of breast compression that a patient should be getting. Check with your radiologist because they know what is going to give great images. Now, we all know 6 pounds of compression is not going to do anything for a patient. The the paddle is barely on the breast under 6 pounds of compression, but if the patient only can tolerate 13 pounds, 15 pounds, maybe even 18 compared to 25 or 26. Just document all of that. And then compressing the breast also reduces that scatter radiation. It's going to decrease the radiation or scatter radiation that is reduced through breast compression. Now we are going to talk about the characteristics of the unit. You have, if you look from top to bottom, starting with the face guard, and then you also should or probably remember this because at this point, I'm sure everyone is probably done with their clinical or maybe preparing for their boards at this time. If you want to, can you let me know in the comments? Because this will also help me from whenever I do the next lesson, how much terminology I can say, or if you're not this far, how much I need to try to put it in layman terms so that you can understand. So it's very helpful if I can know if you are a student, if you're looking into Mammo and you just getting a head start of the information that you would need to know. But the clear plastic plate is called the compression paddle. That is what we're going to use to compress the patient's breast. And then below the compression paddle is the black detector. That is what the patient's breast is going to rest on. And then above the compression paddle is a face guard. This is going to protect the patient's face and also protect the patient's head from getting into the mammo image. So I've had a patient, they was in a wheelchair before, and we had to move the face guard back just a little bit because the patient wasn't able to lean in. When we moved that face guard to see how much breast tissue the patient can get on the detector, the patient's head was in the image or was starting to get in the image. So that face guard is wonderful. Maybe the patient, if you have a patient that's struggling, maybe they can turn their head a certain way and then just lean in a little bit more. But the face guard is needed because it's just going to protect any artifact from getting in the image. Then you have your foot pedals. Your foot pedals at the bottom, you have the red arrow, pink arrow pointing to it. That is what's going to allow the mammo compression paddle to go up and down. And then you can tilt it with the buttons on the side. You can also manually compress by turning the knobs up and down. And then another image of the mammogram tube. Make sure that you know it and then make sure that you understand like each physics behind it. Like what does the tube head does. We all know um, the face guard that protects the patient's face. It also protects the head from getting into the picture. Um, we also have like an automatic release button, which is another thing. If someone is servicing the machine or doing engineering on the machine or doing QA or QC, and that automatic exposure release button gets turned off, make sure you're checking after each picture that the paddle is moving up after take the picture because I've had time where the mammogram machine went down and then like a service engineer had to come out and fix it and the manual button was on. So after I took pictures, the paddle didn't come up and the patient's like, I'm looking at the picture waiting for it to come up and the patient's like, when is this going to lift up? And keep in mind, you may have about 25 to 30 pounds of compression. They don't want us, it's already tough as it is, them having to wait 20 seconds to have the images taken, then the compression powder come up. But 10 seconds, 10 more seconds can be a little bit brutal for them. So check that as you're taking your images. And then also, these are the images that I took at my job. So you have the mammogram machine. This is pretty standard. I've seen a lot of facilities or heard of a lot of facilities using this equipment. So you can see like a better picture of the face shield, the compression paddle, the detector. You have your buttons that you can turn right to left. let it up and down. You also have your foot pedal. So this is pretty cool. So now we're going to talk about the technique with mammogram. So just like X-ray, mammography have a KVP and mass as well. So the KVP range is going to be anywhere between 20 and 40. Lower KVP energy will enhance the image contrast for a better image of the breast. So keep that in mind. The lower the KVP, it can enhance the image contrast, making the image appear better. The mammogram unit is designed to have a cathode at the chest wall and the anode at the opposite side. So if you don't remember what is a cathode, it's a helical shaped tungsten filament or filament, however you pronounce it, or however you was taught to pronounce it. What is an anode? This rotates to allow higher MA to be used with exposure times of less than 1 second. Higher MA increases the image contrast. Now we're going to talk about our SID. In X-ray, when you're doing general X-ray, we all pay attention to the SID because we always, or we know that if you're doing a chest X-ray, it's going to be 72 inches. If you're doing an abdomen study, you're going to move it to 40 inches. So we all know that about X-ray, but with mammography, you really don't really pay attention as much to your SID because the machine is just fixed and you just rotate it and rotate it. So the next time you work, pay attention on the mammography machine of what the SID range is. Just look at it. So SID is source to image receptor distance. This is the distance from the X-ray tube to the image plate. It does affect resolution. A low SID will increase magnification. So the SID is usually set in mammography at 50 to 80 centimeters. Most mammogram units have 65 to 70 centimeters of SID. So to reduce the unsharpness in mammogram or mammography, you need to use a small focal spot. And we have also under SID, you have that pink arrow is going to point to how the better SID is being taken. So whenever you see the arrow, look at the tall source of the X-ray. That's going to give you like a better SID. But when the SID is increased, penumbra is reduced. So keep that in mind. That's what we want. We want the SID to be higher because penumbra is going to cause blurring at the edges of the image. So a large penumbra increases magnification and blurriness on the image. So a small penumbra decreases magnification and blurriness on the image. So whenever you have a higher or larger SID range, the penumbra will be smaller, which that's what we want to reduce any blurriness. Now we are going to talk about the OID, the object to image receptor distance. This is the distance of the object, the body part from the imaging plate. So this is the actual body part. So the OID should be as small as possible. This is going to help with to reduce or minimize magnification. So if you look down here at the picture, you have in figure B, you have a better OID. So just keep that in mind. Whenever you have the object closer to the image receptor, that's going to give a better picture. We use magnification a lot in mammography. A lot of times, if a patient or if something was found on a screening mammogram, the patient will have to come back in to have more images as a diagnostic mammogram, especially if it's for microcalcification. You will have to use the magnification stand and paddle or mag stand. So with this, magnification will reduce the image resolution due to geometric unsharpness. Use a very small focus spot to compensate for the loss in resolution. You have your standard for magnification is 1.5 and 1.8 times. OID is increased when you want to magnify the breast. In magnification or with magnification, grids are not used. A large OID is used and considered an air gap technique to reduce the scatter. Now with our focal spot size, 0.3 millimeters is the most commonly used focal spot size. 0.1 millimeter is the most common focal spot used in magnification. A small focal spot is used when spatial resolution is very important, and a large focal spot is used when a short exposure time is important. So just keep that in mind. For your data acquisition type, you have your 2D mammogram, which is the system that have the X-ray film replaced by solid state detectors. You also have your 3D mammogram, which is very common. That's going to be your digital breast tomosynthesis. That is the new type of digital X-ray for mammograms, and especially with patients with dense breast tissue, 3D mammograms are encouraged because it can see through the breast tissue better, and it would just help avoid the patient having to come back for more follow-up. So I always recommend or encourage my patients to have a 3D mammogram whenever possible. You can also scroll through the 3D image to check for any type of motion to avoid the patient having to come back to the facility. Now, here's a picture or an example of dense breast tissue. Just keep this in mind. You have your fatty breast density, which is going to be the first one to my left, maybe your right. And then you have your scattered breast density, heterogeneous breast density. And then the very last picture is the dense breast density. So you can see any type of cancers and microcalcifications in the fatty breast density well. Whenever you get all the way towards me, that's whenever it can make a little bit more challenging to see through these dense breast density tissues. That's why 3D mammograms are extremely helpful. Now with the image receptor in mammography, the X-ray beam is directed towards the breast whenever the transmitted X-rays are detected by the image receptor. You have the fluorescent screen as well, and then you also have the X-ray spectrum in mammography. That's mostly emitted by a molybdenum target. The good thing about our workstation and monitors and mammography is once we get done taking the picture, we can see the image immediately on our screen if a patient moved or if they couldn't follow instructions well. Then we can see if we need to repeat the image versus having to go to a dark room and process it. And then you also have the radiologists who have their own monitors. They can see a lot better on their screens compared to ours. So whenever we're looking at our screen, we may not see or notice motion, but whenever the radiologists look, they may notice a slight bit of motion and then have to call the patient back. So it's a good habit to get in the habit and motion of checking for patient motion. And then after we are done viewing the images on our work screen, we can decide if we need to annotate different text, if we need to zoom in or zoom out, if we need to flip or rotate the images, we can adjust the brightness. We can check for motion and any type of blurriness. After we are done with our post-processing and annotation, we will send those images to something called DICOM or PACS. So that will allow the radiologist to see the images, and it will also allow us to view previous mammogram images and also resend the images if needed. Whenever you are reviewing your workstation monitors, the radiologist monitor is going to be the one that is going to make the interpretation. So the radiologist cannot interpret or make diagnosis based off of the technologist workstation. They have a better monitor and they can see better. So that's why we just use ours to take the images, check for motion, annotate if we need to, zoom in, zoom out, and then their monitor is best for making diagnosis. Now, whenever the images are being sent over, before you even send anything or take any images, make sure that you have the correct patient, the correct date of birth, the correct exam, because if you accidentally take images under the wrong patient, it may be hard to, number one, it's going to be hard to find those images. And then number two, the wrong patient is going to get the results, or you have the right patient not getting the correct results. So always match up your patient's name from their wristband, if they have one, to their order and the requisition form that you have in your hand. Put it up to the monitor and make sure that you are comparing the names, especially if you have someone who has a similar or the same last name and a similar first name. It's easy to confuse your patients. For your packs, this is what you're going to have to view and store images. This is very helpful, especially in a lot of radiology modalities where you can see previous mammogram, ultrasound, MRI, CT, X-ray exams. If a patient come in the next year, you can see the images from the prior year. You do not have to retrieve images manually or transport images. So the radiologists and us technologists can use packs to view and compare previous images. PACS is very important because images cannot be lost or stolen. You can view multiple images in one system, and it can date back to several years of previous exams. It's easy to retrieve those images. The patients do not have to carry a CD with them. They already have their images from the last time whenever they came to the facility. If they are new to the facility, they will need their prior images. This may come on a CD. This can get sent electronically. So it's very important to get in the habit of knowing how to even work your packs, because this is very helpful if you need to remove an image or if you need to verify or view an image for the radiologist or for yourself. And another tip is, whenever you send your images to PACS, make sure all of it has been sent before you verify it, because when you verify those images, you're putting it on the radiologist's workstation saying, hey, it's ready. You can go ahead and read it. I've done everything. So make sure that you have those CAD images in PACS as well. If you don't know or remember what CAD is a computer-aided detection system that is going to help the radiologist make a detection or a diagnosis of abnormal breast tissue. The radiologists, they still read the images, still do their job, but the CAD is just going to serve like as a second look, especially for those tiny suspicious areas in the breast, such as those microcalcifications, which can be an early sign of breast cancer. That's why the patient will have to come back and get a biopsy if needed. Now we're going to talk about quality assurance and evaluation. QA is very critical in mammo. It is going to help provide high quality images in the mammo and radiology department. This is very helpful in enhancing the patient care experience. And with QA, you also have a QC. Quality control, or QC, is the collection and evaluation of data with systematic and structured mechanisms to control variables such as repeat radiographs from tech repeats, image quality, processing variations, patient selection parameters, technical effectiveness. So this is going to test all of those so that we can implement and make corrections when needed. For accreditation and certification, the FDA requires certification of mammography units for reimbursement by Medicare. To be FDA certified, a facility must first apply to and become accredited by an FDA approved body such as ACR, Arkansas Department, Iowa Department, Texas Department. MQSA was enacted by the United States Congress to regulate the quality of care in mammography. The act was effective on October 1st, 1994. So the purpose of MQSA is just going to establish minimum standards to ensure that all women have access to quality mammography services, meaning whenever we're taking those images, we're making sure that we include all of the body tissue and anatomy. We're making sure there are nipple and profile. We're making sure that we are including the pectoralis muscles. We're getting as much breast tissue in as possible. You have your agencies that is responsible for safety and quality. You have OSHA, a federal agency that establishes the standards for safety in the workplace. The FDA monitors matters from blood-borne pathogens to the disposal of processing chemicals. This requires FDA certification of mammography units for Medicare reimbursement. You have your ACR that is going to provide certification for professionals and technical aspects of mammography services. So ACR started the voluntary accreditation of mammography facilities. I know the group that I work with, they always mention ACR requires this, ACR requires that. So I'm sure they are following all ACR guidelines. You also have the CDC, which is the main federal agency ensuring the protection, health, and safety of people. This is going to develop and apply disease prevention and control. Also, the CDC promotes educational activities to improve the health of people in the United States. So, what is the purpose of all this? You have your accreditation, your certification. Why do we need this? Why is it important? It's important because it's going to ensure that we are taking high quality mammography images. If we do not have this in place, then there is going to be poor image quality. Someone is not going to include all of the breast tissue. You may miss breast cancer. So, this is why we have accreditation and certification in place to make sure that we have high standards and high quality people putting out high quality mammograms, which is going to help the patient in the long run. There are new FDA regulations. This came about on March 10, 2023, where the FDA issued the final rule to amend the MQSA regulation. So pretty much in September 10 in 2024, all facilities was required to notify patients about the density of their breast tissue. This is 2025 when I'm making this. So last year in September of 2024, every facility had to make sure that they were notifying the patient, especially on the report, about what type of breast density tissue they have, whether it's fatty, whether it's extremely dense. They had to notify everyone, which is another example. Just in case you forgot how it looked on the previous slide, this is how the density looks, and this is what patients have to know what they have. And I always encourage my patients, whether they have fatty breasts or extremely dense breasts, they should be getting their mammograms yearly unless their doctor tells them they're done or unless they just cannot come in and get it due to physical or mental limitations. Inspections for your mammography facilities. So, mammography facilities do have to have inspections done. Each mammography system receives a certification. Inspection occurs 60 days after receiving its certification. After the initial inspection, each certified mammo unit is inspected annually. After the facility passed inspection and received their certificate, it will be placed in an area on or near the mammography system unit. So whenever I'm working and whenever you work, check beside your mammography unit. I see a form or a paper. It's like a certificate. It's saying that, hey, it passed, it's certified. You will see that I see it on the wall beside the mammography machine. MQSA regulation for technologists. So this is what's required for techs. So for techs, the MQSA have made certain requirements for us to practice or perform mammo exams. You have to have completed at least 40 hours of documented training specific to mammo under a supervision or qualified instructor. Also, you have to have performed a minimum of 25 examinations under the direct supervision of a qualified individual, someone who already have their mammography license in good standards. Also, you have to complete 15 CEUs every 36 months. The CEU topics must be for mammography related. So it cannot be about x-ray, it cannot be about MRI, it cannot be about ultrasound. It has to be mammography related. Maintain experience by completing 200 examinations every 2 years. What I like to do is at the end of each year, I get the manager to print out my numbers for me. I take it and I put it in my binder at the house and I keep those numbers in case I am inspected. You also have to have 8 hours of training in each mammography modality could be used, such as 3D or digital breast tomosynthesis. You have to have your 8 hours. Whenever I was going through my training, I had my 8 hours as well. Mammography training will not expire if a technologist earned the ARTM or mammography in the past but allowed it to expire. The expired certificates can be accepted as documentation and it will still count towards the 24 hours of initial training. This is very important. Always keep a copy of your initial 25 exam numbers. Keep it in a folder somewhere in your closet. You can also email it to yourself. I email my numbers and I also have it in a folder in the closet. Also, your educational training, such as where you went to school at, whether it was online or whether it was in person. Keep that record for yourself and the certificate for each facility that you work for. Now, infection control. It is very important to make sure that you are wiping down your mammography equipment. I like to wear gloves whenever I take my images. That's just me. That's just what I like to do. I like to have on gloves. And then you also want to make sure that you wear your mask when needed. Like if someone is coughing, I wear my mask whether someone is coughing or not because I think a lot of people are doing this, especially since COVID, where we just have been wearing our masks more or especially if we're very close to a patient whenever we're taking their mammograms, I still wear my mask. I may greet them without my mask, but whenever I'm taking a picture, I have my mask on. Make sure that you are using disinfectant wipes or spray properly. Wear your PPE when needed. Recording your numbers or recording keeping in mammography. So you must have on the mammography results the name of the patient, their MRN number, the date of the exam, the name of the radiologist who is reading or interpreting the mammogram, final assessment findings, meaning what category is it a BIRAS 0, 1, 2, 3, 4. Notify the healthcare provider within 3 to 5 days. The results must be sent to the patient within 30 days. Patients' results must be written in a word or term where they can understand it, such as layman terms. You also have medical audits and mammography. These audits are used to follow positive interpretations and to correlate them with pathology results. The medical audits must track BIRAS 4 and 5. They must be reviewed annually by the lead interpreting physician. You also have HIPAA. HIPAA does not affect the medical audit. Now we're going to talk about enhancing quality using the inspection program. Enhancing quality using the inspection program or EQIP is designed to spot image quality issues early so that it can be corrected, such as those motion artifacts or artifacts in general. Knowing what to do, what to put in place to provide more training in order to reduce the need for technical repeats, providing more training, more educational courses for the techs to learn how to take and image high quality diagnostic images. Make sure that we include all the anatomy whenever possible, knowing how to perform QC, QA, knowing how to notice whenever mistakes are in the QA and QC books. QC for mammography technologies. QC for mammotechs is very critical, it's very important. Most facilities let a lead QC tech do this, or multiple techs who are full time or who understands how to do QC. because you do not want everyone doing it if they don't understand it, if they don't know why they're doing it, what steps come next. So having a consistent QC tech or a designated QC tech, this is going to promote consistency with your QC tests, with your books, accuracy, and reduces errors. Whenever you have a lead QC tech, you know what you're writing, you know how your number's supposed to look. So it is the responsibility of the QC tech to review these books and check to make sure that they are not having any type of mistakes or errors in the book. If so, you have to find who is making those errors and get them to correct. For your QC phantom test, the purpose of the phantom test is to ensure consistent image quality and artifact-free imaging. It should be performed weekly after any service before clinical use or on installation of new equipment. The ACR phantom is required for the phantom test. The new ACR phantom have 6 fibers, 6 spec groups, and 6 masses. You also have 50% of glandular tissue and 50% of adipose tissue is going to be represented by the 4.2 centimeter thick phantom. The phantom is designed to cover the entire detector. Now, to perform the phantom test, you want to use the largest paddle size and the type of flex or fixed paddle. Place the phantom on the detector and center it properly. Compress it to approximately 12 pounds. The same force should be applied each time, and the indicator may not read 4.2 centimeters. Record the exposure mode, paddle size, the compression force, AEC cell position, target, filter, KVP, and density, if applicable. The room number, facility and X-ray unit, and model number should be recorded. Score the fibers greater than or equal to 2, spec groups greater than or equal to 3, and masses greater than or equal to 2. You must repeat any test if it fails and call the engineer, the service engineer. This is an example of whenever I was performing QC. You see how I do not have a face shield on here. I just have the compression paddle. I have the phantom. Then this is the image where you see the fibers, you see the specs, you see the mass group. For QC compression thickness, the purpose of the compression thickness indicates the correct degree of compression. This should be performed monthly on installation of new equipment, and whenever the indicator is suspected to be wrong, compress the phantom to approximately 30 pounds. Record the breast thickness indicated on the machine for the phantom. So for an example, if you see a 4.2 centimeter breast thickness, or a 4.3 centimeter breast thickness, you want to make sure that you record that. Use a spot paddle. Do not use the flex feature. So if you don't know, the flex feature is that little purple button, depending on what machine you're using. If you use the machine that I've shown you in this lesson, then you see the little, it'll be purple buttons kind of like in between the compression paddle and the knobs. You'll see that right there. Compression thickness. So this is an example of a breast thickness measured at 4.3 centimeters. This is me doing the QC. For your visual checklist, the purpose of this is just to make sure all indicator light detents and mechanical locks are in proper working order. This should be performed weekly after any service, before clinical use, or on installation of new equipment. You will need the visual checklist form. The process for performing this is to review all items on the checklist. You want to make sure that you are rotating the C arm of the unit and testing all of the locks. Make sure that you do initial and date the checklist. That's very, very important. This is just an example obtained from the ACR website of just a QC form. And then you also want to do the same thing with the radiologist workstation monitor. This should be tested monthly after any service, before clinical use, after installing the new equipment. To perform the radiologist monitor QC, You want to visually inspect the monitor and wipe away any foreign material using a cloth or cleaning material that is recommended by the manufacturer. Recheck and or re-clean the monitor if needed after it dries. Acquire and display a phantom image. So the score for the phantom image to pass is a fiber score greater than or equal to 2, spec group score greater than or equal to 3, a mass score greater than or equal to 2. You must review the results and record it as pass or fail. For the radiologist monitor results and analysis, reduce the lighting in the radiologist reading room to evaluate the test pattern. So the results for the line pair images at the center and four corners must be visible and you must be able to distinguish it. Correct all failures within 30 days. Correct any blemishes, any type of artifact that is going to interfere with the radiologist viewing and reading the image to make a diagnosis. Okay, for the QC repeat analysis, you want to perform this test with a minimum of 250 patients. This is going to be the information to determine why are we repeating so many mammograms. Is it due to positioning? Is it due to breathing instructions? Maybe we're not communicating with the patient well before we start the exam. So if things like this keep happening over and over, either the supervisor or manager will get with the technologists and see how they can help them reduce the amount of repeats. And also, if they need to talk to the radiologist, they are very helpful as well. Maybe the tech isn't including enough breast tissue. So all of this is going to come when having more training, probably taking more CEUs and educational courses, training with other techs that may be more experienced to help reduce the repeat rate. So repeat results and analysis. So the total repeat rate is equal to the number of repeated images divided by the total number of exposures made times 100. Your reject images, these are the images that are thrown out. The repeat images, these are the images that resulted in increased dose to the patient. The XCCL images do not count as repeated images because these are images that are sometimes needed, especially supplemental if we did not get enough breast tissue on the CC. So repeat images can be related to poor positioning, patient motion, patient or equipment artifact, incorrect patient ID, excessive noise on the image, or overexposures. The problem should be corrected within 30 days. The overall repeat rate should not exceed 2%, but a rate of 5% is acceptable. Your repeat analysis. So get in the habit of being close with your radiologist, checking to see what they like versus what they do not like. So, for example, if you take an image and you do not get all of the IMF, check with your radiologist to see if they prefer you to repeat the image in a 2D or if they want it in a 3D. I always check with the radiologist because everyone is different. You may have a radiologist say, I want it in 2D. You may have a radiologist say, well, do it in 3D. You just don't know. Just go by your facility's policy. This is an example of a repeat reject analysis from ACR. For your QC viewing conditions, the test should be performed weekly. The fluorescent bulb should be changed every 18 to 24 months. Use a window cleaner, soft towels, an anti-static cleaner. Clean the view box, check and remove all marks. So you want to make sure that you are inspecting, checking to make sure there are no dirt or scratches. For your compression force, you want to use a regular calibrated analog bathroom scale. So a scale that has the little lines that go like this. Digital scales do not respond properly when pressure is applied, so do not use a digital scale. Use one of those old scales, like I was saying, you see the line and you see it going different ways whenever you get on the scale and get off the scale. the digital gauges or compression force tools may be used. So make sure that you're always documenting. Performing the QC compression force. So the scale is placed on the detector and use the initial power drive force for compression. Check that force is within 25 to 45 pounds. Release the compression and repeat the manual mode to compress at least 25 pounds. A compression force of at least 25 pounds must be provided for the initial power drive and the manual mode. So for the initial power drive, the maximum compression force should not exceed 45 pounds. If any problems occur, make sure that you call the service engineer. Okay, for the QC detector calibration, the purpose of this test is going to make sure that you check the system gain and calibration, make sure that it is correct. It should be done weekly. This is also known as the detector flat field calibration. So whenever you are performing the test, remove the compression paddle and use the clean flat field phantom by placing it on the mammogram unit or detector. Start the gain and calibration and follow the steps. You want to install the magnification stand whenever it tells you to. Repeat images until you have made all of the exposures. So with this type of QC, you are checking for different shades of gray on the images. Make sure that you are checking to see if there are any artifacts. So I have an example right here. This is whenever, like I was saying, you have to take away the compression paddle. And you see how I brought it down all the way to the phantom. And this is what you should see on the picture. Just make sure that it's, shades of gray. You do not see any big artifacts, any small white specks. Whenever I was doing this, one day, my coworker who was also doing the QC on the same day in a different room, she found this artifact. So it's like very small. So to see this, you have to also have the zoom feature selected to see small artifacts like this. So when things like this happen, you want to make sure that you let your manager know, make sure that you have reached out to a service engineer. And on this day, the mammogram unit could not be used until this problem was serviced. Because if we're looking at this, this could look like a small tumor or calcification. It could look like anything in a patient's breast if we was to keep taking this image. So whenever the artifact was found, a service engineer was called, but this did close down that machine for the day. So whether it took 2 hours or whether it took 6 hours to fix, we couldn't take any images because if we did, what if this was seen in a patient's image? Now they have to come back, maybe have a biopsy or more images. Now they're worried. And what if we didn't even know it was due to an artifact? So if it happens on multiple patients, now you're calling multiple patients back for these type of exams. So that's why you have to do your QC properly, making sure that you are checking for mistakes like this because you can help avoid someone from getting called back, someone from getting surgery or incorrect results. For the medical physicist test, this test is required to conduct an MEE or mammography equipment evaluation of new equipment after major repairs or during an annual test. An annual survey on each unit, 14 months between each surveys are acceptable. For your collimation assessment, this is performed by the medical physicist. The purpose is to ensure that the X-ray field aligns with the light field. The X-ray field should cover the entire detector, but should not allow significant radiation beyond the edges. The compression pattern should align with the chest wall edge of the detector. Performing the collimation assessment. So these are like different steps, but you still have to know it because you have to know it like for your test, know what the medical physicist does. So they will have 5 coins, a collimator detector test tool, and collimation assessment form. The coins are used to outline the light field and provide a visual check in a quick field light test. The light field should indicate a total of misalignment within 2% of the SID. The X-ray field should not extend beyond any edge of the detector by more than 2% of the SID. A tolerance of -2% of the SID on the right and left sides are acceptable. A tolerance of 4% of the SID is acceptable on the side away from the chest wall. For your spatial resolution test, another test that is performed by the medical physicist, this is going to measure the limiting spatial resolution, which indicates the detector performance. It is performed annually as part of the MEE and afterwards. So, spatial resolution is an important term to remember because it is also commonly confused with contrast resolution. So, with spatial resolution, the minimum separation between two objects at which they can be distinguished as two separate objects in the image. So, to perform this test, you will need your ACR phantom, a line pair pattern with frequency up to 10 line pairs per millimeter. And don't forget your spatial resolution form. The spatial resolution must be greater than or equal to 4 line pairs per millimeter for the contact mode and 6 line pairs per millimeter for magnification mode. You have to make sure that all failures are being corrected within 30 days. For SNR and CNR, for your signal to noise ratio, measure the image signal in a given region to the background of the mammography image. Contrast to noise ratio is a measurement of the contrast between a region of interest and the background neighboring tissue in mammography. This can be calculated from the phantom image after it has been obtained. So at the bottom screen, after you're doing the QC, you can see where it say SNR, CNR. You'll just write down that number. The SNR must be greater than or equal to 40. The CNR must be greater than or equal to 2. The CNR change must be greater than or equal to 85%. Make sure that you correct any failed tests before the machine is used for patients. For your AEC, the purpose of this test is just going to make sure that AEC is performing well, is very consistent, and it is detecting the SNR within a certain range of the breast tissue. So compression patterns and the AEC system performance form must be used for this. When performing the AEC test, an exposure is made with 2 centimeters tissue equivalent to the attenuator on the detector. So the compression should be 2 centimeters or 5 pounds. Make sure that you are selecting a large focal spot with the AEC sensor. The test is repeated for magnification. Make sure that you record the AEC mode, exposure compensation, or the density control step, your target, filter, KVP, mask, any type of indication of AGD. AGD stands for average glandular dose. This is the measure to the interest exposure for an average patient, approximately 4.2 centimeters thick compressed breast consisting of 50% glandular, 50% adipose tissue. So you want to make sure that the unit is accurately measuring the average glandular dose. For your beam quality or half value layer, the purpose of this test is to ensure that the half value layer of the X-ray beam is adequate to minimize the patient radiation dose. This should be performed annually as part of the MEE if the technical factors are changed. A 0.1 millimeter thick sheet of 99.9% pure aluminum must be large enough to cover the dosimeter. You want to make sure that it's going to measure the KVP, the half value layer, and the dose, making sure that the KVP should be accurate to within 65% of the indicated KVP. The medical physicist will perform this test. Is going to determine the HVL for all target and filter combinations and making sure that there is a range for the clinical KVP, making sure that you correct all failures. KVP accuracy and reproducibility. The purpose of this test is just making sure that the KVP is accurate and it is reproducible. Making sure that the KVP should be plus or minus 5% and should be coefficient or variation equal to or less than 0.02%. And whenever I'm going through the slides, I just want to say real quickly, you can always go back and watch it, rewind it. This is going to be here on YouTube, so just rewind it and replay it as much as you need to, especially if I'm going fast. So I just wanted to say that real quickly. So for the compression paddle deflection, it must be flat and parallel to the breast support table and should not deflect from the parallel by more than 1 centimeters at a point on the surface of the compression paddle. So this is very important because I know I keep saying this, but just make sure that all failures must be corrected. Even if you do not perform these tests, if you perform the other type of QC test for mammography tests, you have to notify the manager or anyone whenever you see an artifact. This is going to affect the patient in a bad way if you do not. Now we have our acquisition workstation and radiologist workstation. We are going to check for any type of dirt, any type of artifact, making sure that it is clean in order for the radiologist to interpret from it. For the evaluation of the site's Technologist QC program, this is going to be performed annually. The FDA Level 2 non-compliance items can be used as a guide to determine the effectiveness of the Technologist QC documentation. I know at the facility I work for, the radiologists normally review the QC books, making sure that everything is correct. There are no missing words, numbers, or items, making sure everything is scoring correctly, and making sure that everyone is filling out the book correctly. For your radiation dose in mammography, just keep in mind you have your entry skin dose. This is the dose to the patient's skin. Glandular dose, the dose to the glandular tissue of the breast. Your entry surface exposure, you have your range of 800 to 1200. Your millirad, make sure that you know the acronym, the MGY or milligray. Your glandular dose is 100 millirad, and know what ACR recommends. They recommend a 0.3 rad with a grid or a 0.1 rad without a grid. For our technical factors, we have our KVP and our mass. The KVP is going to control the wavelength or the penetrating power of the beam. It's going to be between 20 and 40 KVP. You have your mass, which is going to control the radiation quantity, your optical density, and the patient dose. This should be around 20 to 600. The primary goal of compression in mammography is to reduce the breast thickness uniformly. Our technical factors for mammo that we also use is AEC, which is set. I've looked at the KVP on the machine and I've seen that AEC is on. So the AEC will reduce the chance of repeats and additional radiation dose to the patient. That's what it's used for. It's very helpful for that. You also have your grids, which is going to improve contrast, decrease scatter radiation, and result in more radiation dose to the patient. Technical factors such as magnification. This is used in mammography to look at those small lesions, those microcalcifications. Whenever the patient come in, you do have to put the magnification stand onto the machine to take the pictures. Magnification never uses a grid, so keep that in mind. It does not use a grid. You also have your focal spot size. 0.4 millimeters is used for routine work. 0.3 millimeter is commonly used. 0.15 millimeter or smaller is used for magnification. 0.1 millimeter is common for magnification. Whenever you do label the mammogram image, make sure that you have your annotation or text, such as your initials on the image. You will see it off to the side. You can also use rulers or measurements to measure if a mass is in the breast. how many centimeters from the nipple it is. So it will also state that. You have most facilities have the patient's name, date of birth, the date, facility name, what room that mammogram image was taken in, how much compression was applied, the KVP, the mass, the exposure index, your initials, all of that is on the mammogram image. Mammography target and filters. Make sure that you know all of your targets. Make sure that you know your range. This is very important. Also, whenever you are doing QC, you can see these different targets that you have to change. And whenever you're taking a mammogram image, pay attention to see what filter or target is being used. To evaluate the image quality, make sure that you are positioning your patients correctly. Always document whenever a patient cannot tolerate the positioning or the compression. State whether they are in a wheelchair or not, if they have a walker or a cane. Make sure that you put notes in so that it can help the technologist for the next year. Also, you can check with the radiologist to look at the image even before the patient leaves to see if you need to repeat anything. This is very helpful to make sure that patients do not have to come back. If you made it this far, please feel free to give the video a thumbs up. You can also leave any comments if you have any questions. I do have another lesson coming up. It will be on the anatomy and more things about positioning, tumors, pathology. So that's going to be a good one because that's another one or another category that would take up the bulk of your test. So just watch this video as much as you can. If I went too fast on certain sections, you can always rewind. You can always go back and pause. The video is going to be here free of charge for you to review. I hope you enjoyed this lesson. I hope I broke it down to where you can understand it. So if you have any questions, please let me know in the comment box. Other than that, thank you all for watching. Bye. I'll see you in the next lesson.